Are we ready? Okay, well, good afternoon, everyone. I'm David Roth, and I'm the director of the Center on Aging and Health, and welcome to the scientific seminar series that we sponsor. And today we have a special meeting where we're co-sponsoring our talk today with the Cochlear Center for Hearing and Public Health. So we have a great crowd here in the room, and I hope we have a big group online as well. Before I turn it over to a colleague of mine who will introduce today's speaker, I just want to remind folks that we have another big event coming up later this week. One of the highlights of the academic year is our annual Research on Aging Showcase that is put together by the graduate students and postdoctoral trainees here at Johns Hopkins, as well as at the University of Maryland, and I think with sponsorship as well from NIA. So that's this Thursday over in Sheldon Hall in the School of Public Health building on Wolf Street. The keynote address starts at 12:15, and then the poster competition starts at 1:30. And this year, a special notice that the keynote address is going to be delivered by me. So please try to come and hear what I have to say, as I've been honored this year to give that keynote address. So with that bit of self-promotion, just want to remind everyone that we're very lucky to have funding from the Matthew Tabak Memorial Lecture Fund for this seminar series, and it makes it possible to bring in guest speakers from outside of the university to share their research and their wisdom with us. And today's one of those fortunate days. We also benefit from support and sponsorship from the Epidemiology and Biostatistics of Aging training program and from the Older Americans Independence Center, or the Pepper Center here at Johns Hopkins. So this seminar series has been going on ever since I came here over 11 years ago. I really think it's a very important event, and I appreciate all of you being here today and the sponsorship from those great sponsors. With that, I'm going to turn it over to colleague Dr. Jennifer Deal from the Department of Epidemiology, who's going to introduce today's speaker.
Thank you, Dr. Roth. I'm so glad to hear that you mentioned your keynote address on Thursday. I was going to mention it if you didn't. So welcome, everyone. It really is my great pleasure today to welcome our speaker, Dr. Joshua Ehrlich. He is an assistant professor of ophthalmology and visual sciences, and with the Survey Research Center at the Institute for Social Research at the University of Michigan. He's also the director of the Global Ophthalmology Fellowship at the Kellogg Eye Center. Dr. Ehrlich earned his MPH from the Mailman School of Public Health at Columbia and his MD from Cornell in New York City. He then completed a residency in ophthalmology at the Wills Eye Hospital at the Thomas Jefferson University, followed by 2 research fellowships, the first in epidemiology and health services research, and a second clinical fellowship in glaucoma, both at the University of Michigan. Dr. Ehrlich is a clinician scientist specializing in clinical care of patients with glaucoma, cataract, and anterior segment disease. His research is focused on addressing the adverse impact of vision impairment on health, disability, and quality of life, with a particular focus on older adults, which is why he's here today. His global health work is focused on research collaborations, research capacity building, and strengthening eye care delivery systems globally. Dr. Ehrlich has a very impressive CV, 136 publications, grant funding from NIA, as well as from NIDLR. Importantly, he's also a member of the editorial board at Ophthalmologic Epidemiology. He's an invited member of the Lancet Global Health Commission on Global Eye Health and a collaborator with the Global Burden of Disease Project. And he also serves on the advisory board for the Center for Vision and Population Health at Prevent Blindness. He is also part of the Vision Loss Experts Group, which is a technical advisory group to the World Health Organization and Global Burden of Disease Project. Dr. Ehrlich is really a close partner. He collaborates with the National Health and Aging Trends Study in terms of vision data collection, has a lot of international experience, including in Kenya as well as in India. He's a co-founding member of the Sense Network, which is a network that was founded here out of Hopkins with our partnership with Josh and with a good colleague at the University of Chicago that's really meant to be an international network to connect researchers with an interest in sensory health. He's a very good friend and collaborator for many years. And so please join me in welcoming Dr. Ehrlich today. Thank you.
Thank you so much, Jennifer, for the very kind introduction. And thank you especially to the Cochlear Center, the Center on Aging and Health, and Alden and Jennifer for the very kind invitation to be here today with all of you. It's really a pleasure. And I also wanted to acknowledge the many other collaborators that I have here at Johns Hopkins, Bonnie Sweenor, Frank Lynn, Nick Reed, Jen Schrack, and many from the Department of Ophthalmology, including Alan Robin, who's here today. And so it's really wonderful to be here at Hopkins, where I have so many friends, colleagues, and collaborators. So thank you all. And figure out how this works. So I have no financial interests or disclosures relevant to anything that I'll be discussing today. So I wanted to provide a brief outline of what I'll be touching on. The talk today is sort of divided into thirds. I'll first talk a bit about the epidemiology of vision impairment in older adults, some patterns, some data gaps, opportunities for future work. I'll then turn to talk about some of the implications for health and well-being that vision impairment holds for older adults. And then the third component of the talk will really be a focus squarely on vision and dementia. And so we'll start talking about some epidemiology. And I'd like to frame this in the context that many in the audience today are undoubtedly familiar with, which is that the world's population is aging. The over 60 population globally is supposed to reach about 2 billion people by 2050, but here we are today at around 1 billion. So that's a big increase with profound implications for economics, for health delivery systems, you name it. So everything we'll talk about is sort of nested in this context. It may not surprise anyone that the prevalence of vision problems also increases with age. Here we can see by decade the global estimates of prevalence of blindness and vision impairment, starting with age 50 to 59 and going up to 90 plus. And we see this stepwise increase in the prevalence of vision impairment and blindness. This is largely a function of many of the common causes of vision impairment being conditions of aging. When we think about common eye diseases that many of you likely heard of, cataract, glaucoma, macular degeneration, these all become much more common with each decade of life. And so much like the over 60 population is projected to increase precipitously over the coming decade, the number of people with vision loss is projected to concomitantly increase over that same time period. And this is largely because the number one risk factor for vision impairment and blindness is age. This is about a 60% increase over this time period. Now, this is true even though we're doing better at taking care of people's eyes and vision. Over the past 30 years, we've seen a decrease in the age standardized prevalence of vision impairment and blindness in every single region of the world. This has largely been achieved through global advocacy, advances in preventative medicine and delivery of care, and even some key scientific developments in vision care. But as noted, the aging of populations, both here in the US as well as globally, has this outsized impact that even as age standardized prevalence decreases, because the population of older adults is so large and is growing so much, the number of cases will continue to increase. Now turning to thinking a little bit about what's causing vision impairment and blindness, this pie chart here is an illustration of the global causes of vision impairment and blindness. And what I'd like to point to are the blue slices of the pie here, which one can pretty easily see comprise more than 3/4 of the pie. These two blue slices of the pie refer to refractive disorders, that is the need for glasses, and cataract. And we'll talk a little bit more about why that's significant in a few moments. But suffice it to say for now that those are both readily addressable with fairly accessible interventions the world over. Now, the pattern varies from country to country, region to region, but the pattern is not terribly dissimilar here in the United States to what we see on the screen right here. But much of the data that I've shown you thus far does come from global estimates. So what about the US? What do we know? Well, much of what we know about vision health at a national scale in the United States comes from self-reported data, that is asking people, how well do you see? Many of the large national surveys with which many in this audience are undoubtedly familiar have self-report questions about vision. This is not a problem per se, but it's important to recognize, and I had some great conversations earlier today with some of the trainees here at COA about this, that self-report is measuring a highly correlated but distinct construct compared to objectively measured vision. Self-report is a more disability-centered construct about how one's vision is impacting their daily life, how one perceives their own visual difficulty or ease. Whereas objective measures of vision, reading a vision chart on the wall, is a physiologic measure. It's a measure of how well the eye and the visual system is functioning. Highly correlated, but distinct. Objective measurement in national studies in the United States has been very, very rare. We do have some locally representative data from smaller studies that have been done in specific locations throughout the country, but the last national data up until very recently was from 2008 from NHANES. So we went quite some time until 2021 without any national data to guide us on what was going on epidemiologically, specifically with older adults who are the primary at-risk group for vision impairment. So several years ago, we proposed to address this shortcoming in the data. We sought to integrate vision tests into the nationally representative National Health and Aging Trends Study, which is jointly run out of Johns Hopkins and University of Michigan, so very apropos to discuss here. We proposed to develop a set of measures that fit well with the NHATS framework. And to understand what I mean by that, it's important to understand that NHATS is a study of late life disability. That's squarely the focus of NHATS. So we sought to develop a set of objective vision measures that would tell us something about how people might be getting by in their daily life and how vision might be impacting other aspects of health and disability. That's to say that the measures we developed test vision with both eyes open rather than each eye separately, and they test people with glasses if they have them, without glasses if they don't have them, because that's how people are living their everyday life. And so if we want to know how vision is impacting, let's say, fall risk, well, it's not important in that context so much to think about how good we could get someone's vision if they had the optimal prescription in their glasses. It's important to think about how they're living their life with both eyes open, with the vision as they bring it to the table. So this is sort of the underlying rationale behind the way we test vision in NHATS. The tests had to be very portable because NHATS is administered in participants' homes. And as Jen Schrack here could definitely tell us, it's a lengthy study that requires a lot of materials and is arduous for the interviewers. And so we wanted to minimize the additional burden on the interviewers going into the homes. So we developed, working with an optometrist expert in psychophysics, a set of iPad-based measures that would be rather compact. And we sought to measure 3 constructs that I'll delve into in the next couple of slides. 3 measures. So the first of those is the vision measure that is most commonly measured. If you go into an optometry or an ophthalmology clinic and they have you read from an eye chart on the wall, as many or all of us have undoubtedly done, they're measuring distance visual acuity. And that relates very, very well to to our vision for things like driving, things we need to do with looking out at the world. To test this, participants are seated. The iPad is placed on a table 1.5 meters away from the participant. And if the participant reads at least 3 of the letters correctly on a screen like this one, then they get credit for those 3 letters. And we advance to the next screen of smaller letters. And it goes on like this until the participant either reaches the screen with the smallest letters or is unable to read at least 3 of the letters on the screen. There's also a near acuity test, which is tested at the participant's preferred reading distance. And the same stop pattern is used to test acuity, to test near acuity. And then finally, there's a test that many in the audience may be a little less familiar with called contrast sensitivity. Here, the participant is again seated 1.5 meters from the iPad. And if at least 1 letter is read on the screen, they'll advance to the next screen. And on each successive screen, the letters become lower contrast. That is, the gray becomes lighter, becomes whiter. harder to detect. For each of these three tests, the number of letters read correctly is converted to a log scaled measurement, which then facilitates all sorts of parametric statistics as opposed to the commonly used, say, 20/20 or 20/40 measurement that many of you may have heard of. So prior to integrating these tests into NHATS, we conducted some studies. The first of these studies was done to test whether or not these measures were concordant with some of the clinical and clinical trial gold standard measures of vision that are commonly used in vision research. And for those interested, these are like ETDRS visual acuity and Pelley-Robson contrast sensitivity. And we found very tight limits of agreement, and we didn't find bias in the tests when we evaluated them against gold standards. In a second study, we looked at acceptance, and we analyzed for interviewer effects in a 400-person pilot of actual NHATS respondents, and found very high acceptance of the measures, high completion rates, and very minimal to no interviewer effects. So we felt pretty good. In 2021, NHATS adopted and deployed these measures in the national sample for the first time, both vision and hearing, in fact, in sensory battery. And NHATS is continuing to do so going forward, administering these measures year after year to the panel in the National Health and Aging Trends Study. This, really importantly, I want to drive home the point, provides the research community and the vision science community with the first national objectively measured vision data in more than 14 years. In fact, if we even compare it to the data from 14 years ago, which came from NHANES, these data are actually much better equipped to provide estimates of visual function, for example, in the oldest old, who were not included in any substantial number in NHANES. And the panel design, rather than the cross-sectional design of NHANES, the panel design of NHATS will enable many other insights using the rich data in NHATS on late life disability, health, and well-being to study trajectories, as well as in the future to estimate incidence. And so in this recent analysis, what we found was a very high prevalence of vision problems. When adding together any vision impairment, near, distance, or contrast, and there was a lot of overlap, many people had multiple impairments, more than 1/4 of adults aged 71 and older had a vision impairment. There was a higher prevalence as we increased in age, as can be seen in the graph right here, among those with lower education, lower income, and races and ethnicities other than non-Hispanic white. But even with this exciting new data that really provides us with epidemiological insights we haven't had in a decade and a half, there are quite a number of current data gaps that still exist here in the United States when we think about vision and vision epidemiology. We have very little national and representative cause-specific data. The cause-specific data we have largely comes from electronic health records, which are biased to a care-seeking population, much like insurance claims are biased to a care-seeking population, or from small area studies that may or may not be generalizable nationally. We also have never been able to make incidence estimates around vision impairment and blindness in the United States for older adults. This is something that NHATS will enable going forward as we continue to test vision year after year. And then certainly there's a need to better understand within country variation among key geographic and demographic groups. And some of this will be addressable with future rounds of the data that we're collecting, while others certainly are going to require novel solutions and perhaps novel data collection. But these are some of the areas that we're thinking about and that the vision research community is certainly thinking about when we think about epidemiology in this space. I'll pause in case anybody has questions about some of this before I move on to the next section of the talk, and I can certainly take questions at the end. I don't know, do you prefer one way or the other? No. Okay.
No. Hi, this is Anna Koharska-Newton from UNC. I do have a question, by the way, great talk. The question is, why do you expect to see geographic variation in vision impairment? Is it a matter, are you going to dig further into it with respect to healthcare access and things around that? Or
Yes.
overall economic issues, or tell me what your hypothesis is.
Yes, I mean, the answer, so I don't necessarily say that with a specific hypothesis in mind, but I think everything that you're alluding to is quite possible, and I think there's good reason to believe it to be the case. Certainly the distribution of vision care providers in the United States is not equitable. Rural areas have many fewer vision care providers, and it may be the case that we see rurality is associated with vision impairment, that there's a greater need for for delivery of vision care services in certain places. I also would imagine, would hypothesize, if we were to go there, that things like the area deprivation index or Gini coefficients would be associated with the prevalence of vision impairment, and could be helpful for directing resources to places where they're most in need. There's also some interesting there's a CDC run system called the Vision Eye Health Surveillance System that is now integrating this new NHATS data, but has relied on some of the older NHANES data and some of the self-report data to try to provide a snapshot of vision and eye health epidemiology in the United States. It's a publicly accessible website. It's easy to, VEHSS, very easy to pull up. But that system has also been useful in identifying some hotspots where it looks like the prevalence of vision impairment is particularly high. And although NHATS is not representative at the state or the county level, it may also be helpful for identifying certain areas where additional work is needed because it looks like there may be something going on there. And certainly it can augment some of these other data sources that the CDC system is already using to help to identify geographic variation.
Thank you.
On the chat, which is from Dr. Richie Sherritt. How do you define impairment in contrast?
Yeah, that's a really good question. There are no standards for defining impairment in contrast sensitivity, so we took two approaches. One approach was to look at those who are greater than a standard deviation below the sample mean in NHATS. The other approach, there was a publication from a number of years ago that came out from, I believe it was from somewhere in Northern Europe, that tried to define sort of a population normals in contrast sensitivity. It's a relatively small study, but it's kind of what everybody's used ever since to define what is normal and what is abnormal. And I believe the threshold, if I'm remembering correctly, was 1.55 log contrast that paper defined. So one can use that or the one standard deviation sample mean, and we actually did both in that paper that I just was showing some figures from, and show the estimates both ways, because the truth is there's no accepted standard in the community. It's a great question.
Hi, Josh. This is Allie Abraham, University of Colorado. So I noticed on the graph, and this is sort of related to the last question, the prevalence of contrast sensitivity impairment and the prevalence of distance acuity impairment seem to be exactly the same across all the age groups, unless I misread that. Yeah, so that's striking.
Very close.
Yeah. Do you have any thoughts on why that is? I just don't recall seeing that previously.
Yeah, I don't know that we've, well, yeah, I mean, I don't know that we've seen these graphs previously testing these two things necessarily. It's not complete overlap in individuals, interestingly, right? So although the prevalence tracks quite, I mean, we can see here on the graph quite well, it's not necessarily the same individuals with contrast impairment and distance impairment, although they are highly correlated. You're much more likely to have one if you have the other. There's some thought, and I don't think I included the data in this talk, there's some thought that contrast sensitivity impairment is oftentimes will appear, or decrements in contrast will appear before some of our more common clinical manifestations like distance acuity decrease. And so it may be that, on that basis, one might expect a higher prevalence of contrast sensitivity impairment, which we don't really see here, maybe slightly higher at some points. But I don't have a great answer there. It's not complete overlap, but it's highly correlated.
All right, thanks.
So I'll move on to the second section of the talk, where I'm going to talk a little bit about the implications of vision impairment for a few different aspects of life, health, and well-being for older adults. So this figure comes from the Lancet Commission on Global Eye Health, a report that came out in 2021, which highlights some of the key areas with links to vision in its report and in this figure. And really the figure is meant to drive home the point that the influence of vision impairment on health and well-being of older adults is wide-ranging, with the caveat that causal data does not exist for many of these links that are drawn, although I think we're sort of gaining a little traction towards moving toward establishing some of that causality. Some of the highlighted areas that the commission focused on include injuries, depression, dementia, cardiometabolic conditions like diabetes, hypertension, and stroke, cancer, and even mortality. And I'll highlight a couple of these moving on. In fact, it's the case that eye health has actually been linked to nearly all of the United Nations Sustainable Development Goals, with which some of you may be familiar. This is also a figure that was drawn from the Commission report, showing how the research implicates vision impairment in many of the SDGs. Some of the Sustainable Development Goals for which there is the greatest evidence for vision impairment playing an important role include 3, 4, and 8, which are respectively good health and well-being, quality education, which does have important implications for older adults, and decent work and economic growth, SDG 8. And in fact, the relevance of vision to the Sustainable Development Goals is so paramount that it even resulted in a resolution being passed by the United Nations General Assembly acknowledging this fact and specifically calling on constituent countries to establish vision health action plans and to report back to the UN and WHO on key eye health indicators. So really quite an important potential lever for actualizing some of these sustainable development goals globally. As noted in some of the SDG slides, vision impairment may have important implications for economic well-being. This is true both in low and middle income countries, as well as in the US and in other high income countries. However, the source of economic hardship may vary. In high income countries, including the United States, direct medical costs and long-term care costs are major contributors to the economic burden of vision impairment. In low and middle income countries, disability often affects entire families and can have profound intergenerational impacts, for example, with school children staying home to care for older blind relatives, which is unfortunately a common occurrence in many areas of the world. This is actually in the Rohingya refugee areas in Bangladesh. However, we now know that these large and significant implications that vision impairment has for economics and productivity may be modifiable, even using very inexpensive interventions like over-the-counter reading glasses. And so this study here was a randomized controlled trial in which tea pickers in Assam, India, were provided over-the-counter reading glasses like you would get at the corner drugstore. A third of participants in the study were aged 50 or older, and the total cost of the intervention, including delivery to deliver the glasses to these very rural areas, was about $10 per participant. The randomized controlled trial showed that the between group difference in productivity was markedly significant. So people who received the eyeglasses were picking 5 kilos more per day of tea. That's a lot of tea. That's a big difference. These increases were actually more marked in the older age groups. There was some effect modification by age, where the age 50 and older tea pickers were actually picking over 7 kilos more of tea each day. Additionally, with age, perhaps not surprisingly, willingness to pay for glasses out of one's pocket also increased. So this suggests, this is one piece of the puzzle, sort of suggesting that vision may be one of these important levers for really making change in people's lives. So vision impairment, it turns out, not only influences health conditions and economic circumstances, but may also be associated with even mortality. As part of the Lancet Commission on Global Eye Health, our group conducted a systematic review and meta-analysis to try to understand a little bit better what the evidence in this space shows. And we found that there have been 28 studies conducted in over 12 countries, and about 17 of these had quantitative data that could be meta-analyzed. And this is how the data was distributed globally, or how the studies were distributed globally that were included in this systematic review and meta-analysis. Clearly, there's data missing from some parts of the world. There's nothing in Latin America. The US and Western Europe are predictably overrepresented. But this is what we found in 2021 was out there. And the take home really was that the hazard of all-cause mortality seemed to increase as the magnitude of vision impairment increased. So people are more likely to die, it seems, from the existing data if their vision is worse. So taken together, the evidence points to certainly, I would say, a concerning effect of vision impairment on a host of adverse health outcomes and economic circumstances. And I've not really gotten into, say, fall risk, which is another area where there's considerable evidence, not surprisingly, that vision impairment may play an important and modifiable role. But I'd like to point out that there's still relatively little interventional evidence. It's exciting to point to the RCTs that we have, like the PROSPER trial that I pointed out, but there's definitely a large need, not only so that we know scientifically, but so that we can move the ball on policy for us to generate this interventional evidence showing that vision is this important lever we believe it to be. So now I'm going to spend a good while here talking about vision and dementia, because I think in many ways, this is a space, this is a distal health outcome that vision is associated with, that there's been a bit more work on, but still quite a bit of need for additional work. It's a space that I've done a fair deal of work, and one that I think may be of interest to many in the audience. And so, as many of you are likely aware, just like the aging population is growing and the prevalence of vision impairment is growing, the prevalence of dementia is also projected to increase rapidly over coming decades. And in fact, and importantly, a large fraction of new dementia cases are going to happen in low and middle income countries, in places that have really not dealt with an epidemic of dementia like we have and continue to and will continue to address here in the United States and in other high income settings. Excuse me. Thus, globally, I think one can probably agree that there's a large and even growing need to identify potentially modifiable risk factors for dementia that could be intervened upon to potentially slow cognitive decline or even prevent incident dementia cases. So I'm sure a lot of folks are familiar with the Lancet Commission on Dementia, Prevention and Intervention, that issued a report in 2017 and then again in 2020 that sought to develop this life course model of dementia risk factors. And they scoured the literature and they identified what they thought were what they held up as the 12 potentially modifiable dementia risk factors in the literature. And these were lower education, hearing loss, traumatic brain injury, alcohol intake, obesity, smoking, depression, social isolation, physical inactivity, diabetes, and air pollution. No vision. Those from the Cochlear Center in particular are quite aware that hearing loss was calculated to be the risk factor associated with the greatest number of cases worldwide of dementia. And for a number of reasons that I'll go into, it was really surprising when the 2020 report was done, a rehashing of 2017, and new risk factors were added, that we still didn't find vision in the 2020 report. Now, this is important not only because we think vision should be included, we're vision researchers, but because the Lancet Commission report is actually a really important document. It drives international policy, it drives funding priorities, and it has a lot of influence. And so for all of those reasons, we fully expected and hoped it would be included. So I'll kind of go through some of the reasons why this surprised me. So first, the totality of the evidence for vision impairment as a dementia risk factor is reasonably similar to the #1 risk factor, hearing loss. There's a similar magnitude of effect, and the body of longitudinal studies that in 2020 had been conducted to examine this association was pretty similar. Second, the hypothesized pathways linking vision impairment and hearing loss to dementia are really the same. I'll return to discuss really all of these pathways in some detail a little bit later, but suffice it to say for now that the hypotheses really hold for vision and for hearing, although we need to prove the hypotheses. Right now, they're still hypotheses. We need to test them. Third, the prevalence of vision impairment is high, particularly in older adults, those who are at risk for dementia. Many people, we can see more than 1 billion globally will experience some form of vision impairment in their lifetimes, and the vast majority are in individuals 50 and older. And then the final reason, and this gets back to that pie chart that illustrated the causes of vision impairment globally, is that an estimated 80 to 90% of vision impairment is preventable or has simply yet to be addressed. So that 3/4 of the pie chart that were made up by refractive error and cataract, providing glasses and performing cataract surgery are 2 of the most cost-effective interventions in all of medicine. And they're safe and they're effective. So surprising for that reason as well. It's modifiable. So I think it's safe to say that there's considerable reason to at least explore healthy vision as a potential lever here to optimize cognitive health. So this framework was proposed several years ago by an expert panel, and based on the existing evidence for the relationship between vision impairment and hearing loss with cognitive decline. And we'll kind of break down this framework a little bit. So one possibility that's been put forth is that there's some common cause, some common etiology underlying cognitive function and visual function. And that could be neurodegenerative, that could be vasculopathic, some combination thereof, that results in both declines in cognitive function as well as declines in visual function. Another possibility is sort of broadly termed the sensory loss consequence hypothesis or pathway, which posits several possible mediating pathways that could link vision impairment with cognitive health. And I'll talk a bit about those a little bit later, but we can see here what some of those hypothetical mediators are. So while we do have gaps in our understanding of this association, there has been considerable research conducted to establish that a relationship, an association, exists between visual and cognitive health. We know that older adults with vision impairment are, at any cross-section, more likely to be cognitively impaired. And when we look longitudinally, there's evidence to show that there's an increased risk of cognitive decline and incident dementia among those with vision impairment. So I'll delve into a little bit of this data. Don't have to just take my word for it that it exists. So some of the most up-to-date cross-sectional data I can show you is some work that we've recently been doing using this new NHATS data, the national data from 2021, which shows an increased prevalence of dementia among those with all forms of vision impairment, whether it's near vision impairment, distance vision impairment, or contrast sensitivity impairment. And in the future, we anticipate being able to take this a step further, of course, as we continue to test both vision and cognitive health in future rounds of NHATS to understand what's happening to cognitive trajectories and to the cumulative incidence of dementia in the NHATS panel. When we think about longitudinal associations, the group here at Johns Hopkins used locally representative data from the Salisbury Eye Evaluation Study, a population-based sample from Salisbury, Maryland, to analyze the longitudinal association of vision impairment with cognitive function as measured by the mini-mental state exam. In addition, they looked in both directions. They asked the question, is this bidirectional? Does vision impact cognitive health? Does cognitive health impact vision? And if so, if it is bidirectional, which direction seems to be stronger? What seems to sort of be driving the association? So they use this technique of cross-lag models and found that, in fact, there is a bidirectional association. And this is something that's also been shown in subsequent other studies. But the key point made in this paper is that vision appears to drive cognitive function, and that as the association in that direction was significantly stronger than the reverse association. It was larger and seemed to be the driver here. So another locally representative study, the Beaver Dam eye study and the Beaver Dam offspring study, have provided considerable insight into the temporal relationships between vision impairment and cognitive health. And in addition to looking at the association of vision impairment with cognition, this study that I highlight here also explored the relationship between other risk factors like cardiovascular disease and hearing loss with dementia and cognitive decline. I found this study very compelling for a reason that I mentioned a few minutes ago in addressing one of the audience questions, in that they focused on contrast sensitivity impairment as their marker of vision loss. And that was intriguing because contrast sensitivity is not the most common measure of vision loss, but there is some evidence that contrast may be lost earlier in the process of visual decline. And so it may be perhaps a better marker of what's going on in the visual system than distance visual acuity. So I found this somewhat compelling. We can see that their outcome, which was incident cognitive impairment, was defined. It was defined using a principal component analysis, using these various measures of cognitive health. Again, it was locally representative from a population in southern Wisconsin. And what they found was that vision was actually one of the stronger drivers of each of the outcomes measured: incident cognitive impairment, as well as decline on the trail making A and B test. So in a related analysis, the same group from University of Wisconsin conducted from the parent epidemiology of hearing loss study, which that was the parent study, the Beaver Dam offspring study was drawn from that. The investigators analyzed, interestingly, the sensitivity and specificity of sensory impairments as screening tools for dementia, or for cognitive impairment, rather. They found, of course, that many people with cognitive impairment will not have a sensory impairment, and that a sizable, albeit somewhat smaller fraction of those with a single sensory impairment will also not have cognitive impairment. As an aside, in the very small group, less than 5%, that had 3 sensory impairments, hearing, vision, and olfaction, the specificity for detecting cognitive impairment was actually very high, which is just sort of an interesting aside, 97%. So after we read this, our group asked the question, maybe it's possible to better define who with vision impairment is likely to go on to be cognitively impaired or to have dementia, understanding that many people are going to be visually impaired and many are going to remain cognitively normal. So to attempt to get at this, we use data from the Aging, Demographics, and Memory Study, or ADAMS. ADAMS was a sub-study of the health and retirement study done in the early 2000s. It included people aged 70 years and older at various levels purposely of cognitive risk. And it was a nationally representative sample, although small compared to the parent HRS study. So our hypothesis was that vision impairment may act as a second hit among those who are ApoE4 allele carriers. ApoE is the strongest known genetic risk factor for dementia. And so we thought, well, maybe it's those ApoE carriers that when they get vision impairment, it kind of tips them over the edge. And what we found was that, and we analyzed various risk factors for which there were good indicators in the ADAMS data, dementia risk factors, and we found that there was a considerably elevated joint effect. That is an effect among people who had the ApoE allele, 1 or 2 copies, and the other risk factor, whether it was vision or something else. Turns out the joint effect for vision and ApoE was the highest of any of the joint effects, over 11, as compared to those with neither risk factor, no ApoE and no vision impairment. So some Again, a relatively small sample size as compared to the parent HRS, but some compelling data that perhaps there's something to this kind of two-hit hypothesis, that we can maybe start delving in as we get better samples, better data, delving into the data to understand not just the summary associations. Hey, at a population level, there's a 30% increased risk if you're visually impaired, but who really are the at-risk groups that are driving that summary association? With that context, we also sought to understand when in the course of cognitive decline, vision impairment plays a role. That is, we wanted to know, is vision impairment driving early cognitive transitions, movement from a normal cognitive status to mild cognitive impairment? Or is it driving later cognitive transitions, that is a movement from mild cognitive impairment to full dementia, or both? And so we use the ADAMS data to try to look at this question as well. And I think to understand this, it's helpful to know a little bit more about the design of ADAMS. ADAMS recruited folks from, I believe it was the 1999 and 2000 HRS fieldings, and assessments ran from 2001 to 2009. They were really in-depth assessments. They included geriatricians, neuropsychologists, and they involved in-person interviews, reviews of medical records, really, really rigorous. And then a consensus panel met with all of this evidence to discuss and come up with a diagnosis for each participant. So that was done at wave A for everybody. Wave B, they had some cases that there was some discrepancies or maybe some argument about what the true cognitive status of the individual was. So these people were reassessed. And then wave C and D, anyone who was living and had not yet met the endpoint of dementia was assessed yet again. And so there was about an 8-year period of assessments here between waves A and D. And we have 1 to 4 waves, depending, since some people died and others reached the endpoint of dementia. So what we did is we first examined the overall association. We said, what's the association between vision impairment and dementia in this sample? And we found a significantly elevated hazard of developing dementia. It was 1.63 was the hazard ratio in the fully adjusted model. We then said, well, what if we sort of decompose this and look longitudinally and look at the hazard for transitioning from normal to mild cognitive impairment and the hazard for transitioning from mild cognitive impairment to dementia. And what we found was that it seems vision impairment is driving those early transitions and only those early transitions. There was a completely null effect when we looked at people with mild cognitive impairment and analyzed the association of vision impairment with incident dementia. What we believe this is showing us is that once somebody develops mild cognitive impairment, it doesn't matter as much for their cognitive health if they're visually impaired, because in some ways, even though many people with MCI will go back to being sort of cognitively normal, in many ways, because dementia risk is so elevated in the population with mild cognitive impairment, the cat is already out of the bag. Vision seems to be less important at that point, but quite important for those folks who are cognitively normal in terms of whether or not they remain cognitively normal or go on to develop mild cognitive impairment. So we believe that's driving the summary association and the summary between vision and dementia. So now that we know that all of that evidence is there, returning to the Lancet Commission report with all of this evidence, and the vast majority of it existed before 2020, where is vision in the Lancet Commission risk factor model? It wasn't there, as we've said. So we sought to replicate the Lancet Commission model using US data and including vision impairment in their own model to try to understand what impact that might have on the model itself. The Lancet Commission model estimates population attributable fractions, or the fraction of cases in the population that are strongly associated with that risk factor. The Lancet Commission states that PAFs are an estimate of the number of cases that would be eliminated if that risk factor were eliminated. That's, I think, debatable, but in any case, the PAF is the statistic that they calculate. We found when we put vision into their model that the PAF for vision, the population attributable fraction, was about 2%, comparable in the United States to social isolation, another factor in the model, greater than alcohol abuse, another factor, and that about 100,000 cases of prevalent dementia in the United States were attributable or strongly associated with at least vision impairment. We see this PAF in other places where we've looked at it in data that I'm not showing today, increase considerably in places where the prevalence of vision impairment is much higher than the United States. Like, for example, in India, there's 6 times more vision impairment. And we see a very high PAF for vision impairment, where it's one of the strongest risk factors there. So the purpose here was really to kind of show the community, hey, maybe we should be considering vision in this model when we're looking at key and important risk factors, and to kind of draw attention to the importance of vision as a potentially modifiable risk factor for all the reasons we talked about. It turned out that the work garnered a lot more interest and attention than we ever could have anticipated with the publication in JAMA Neurology. Turns out publishing in the New York Times gets a lot more readers. So our work got a fair deal of attention, which we were certainly happy about. Even with all of this data and knowledge about the association between vision impairment and dementia, there are some major unresolved issues that our field really needs to focus on. One of these is around mechanistic pathways. And we've talked a little bit about that, but I'll delve in a little more here. We have some of the mediators that I highlighted before: social isolation, psychological well-being, and reduced activity. Those are all modifiable risk factors in the Lancet model because they are strongly associated with cognitive function. Well, it turns out the vision literature tells us that they're also strongly associated with vision impairment. People who are visually impaired are more likely to be socially isolated, more likely to experience depressive symptoms and symptoms of anxiety, and are more likely to be physically inactive and have smaller life spaces, travel shorter distances from home. Much of that work was conducted here at Hopkins by Pradeep Ramalu's work group. And so there's good reason to think that these may be mediators. It may be that people lose vision, socially withdraw, or become less active, and that could be a reason that cognitive function is declining. Another possibility may be direct alteration of brain structure and function. With decreased afferent input into the occipital lobe of the brain, with less visual information coming into the brain, this may alter the function of the brain over time. Cognitive load may also play a role. For example, dual tasking may require more cognitive load in people who can't see as well. And this increased cognitive load can have a long-term effect on brain health, perhaps. So these sort of mediating pathways have not been well tested, certainly an area for more research. Another possibility, or another area that requires, I would say, more attention is a better understanding of the influence of age of onset. So we here are interested largely in vision impairment in older adults, but the age at which people become visually impaired could have implications for their cognitive health. We don't have great data there. But there is some data from the vision literature that suggests less compensatory adaptation to vision loss and less sensory substitution among those who acquire vision loss later in life. But as noted, the implications for late life cognitive health are not well studied, and research is really needed to understand whether age of onset plays a role, or simply perhaps whether you're a good adapter plays a role at any life stage. Perhaps adaptation, sensory substitution may buffer against cognitive decline, and that may explain why some folks with vision impairment go on to experience cognitive decline while others do not. And then finally, the real sort of million-dollar question: can improving vision slow cognitive decline and prevent dementia? The interventional evidence, which we don't really yet have, although I would say that the best evidence we have pushing us in that direction comes from a study published last year in which Cecilia Lee's group at University of Washington published what I would consider to be kind of the most compelling in this space. They studied over 3,000 older adults in a population-based study in Washington State from the Kaiser Permanente Health System. And they found that cataract extraction, which is a vision improving intervention, was associated with a lower risk of developing subsequent dementia. But this was their negative control, that glaucoma surgery, which does not improve vision, did not have an effect on subsequent dementia risk. So while this is really compelling research and an excellent paper, it's still retrospective. It was not randomized, and so it's still susceptible to unmeasured confounding. So when we then move towards considering randomized controlled trials that could be undertaken in an attempt to slow cognitive decline, maybe even prevent dementia, really, I would argue that the space we should be thinking about are these readily correctable causes of vision loss that affect more than 3/4 of those folks, older adults, who have vision impairment. Highly prevalent, highly correctable. Eyeglasses and cataract surgery. And in fact, a group from Queen's University Belfast in Northern Ireland that I'm working with has designed Clever, the cognitive level enhancement through vision exams and refraction, a randomized controlled trial that is just getting off the ground in Hyderabad, India, where older adults will be randomized to receive immediate or delayed intervention of refractive correction, and will be following their cognitive trajectories to discern whether or not correction of vision may in fact have a positive impact on cognitive health. And so with that, I'll leave you with a few concluding thoughts as we're nearing about an hour here. Many older adults experience vision impairment. It's a highly prevalent condition. And as noted, the number affected by vision impairment is growing, not because the age standardized prevalence is increasing, but because the population is aging. We know now also that vision impairment impacts many facets of life, including cognitive health. And importantly, that it's modifiable in a vast majority of cases, and may be this lever to optimize late life health and well-being. And I'd like to acknowledge my collaborators and my team at University of Michigan, many of my colleagues here at Johns Hopkins, who've worked with me on some of the projects I've presented here, as well as, of course, our funders, the National Institutes of Health, Research to Prevent Blindness, and Wellcome Trust. And I would be happy to take any and all questions.
Yeah, I have a comment that was very interesting and thorough and so on. And I was struck by your saying that you thought the mechanisms that might explain an association of poor vision with dementia might be similar to those that explain poor hearing. And against that, it is my uninformed impression that hearing affects social engagement at a much less severe stage than vision does. And while, as you have shown, that vision impairment at an arbitrary cut point has a similar relative risk for dementia as vision impairment, again at a arbitrary cut point, you really need to do that PAF stuff that you did to compare it with the big report. And when you did look at that, vision turned out to be, well, 2% of the dementia appeared to be due to vision, which belies, I think, the relative risks that you showed as being similar for vision and hearing. And I think the answer is simply you were comparing a more severe vision loss with a less severe hearing loss. My impression may be wrong, so your comments are
I think
of interest.
Thank you. Thank you for the question, the comment. The difference in the PAFs is driven entirely, 99%, by the difference in prevalence. So the prevalence of vision impairment that was used in that analysis, and in many analyses, is distance vision impairment. Distance vision impairment is thought to be a good marker of the functioning of the eyeball, whereas near vision impairment also picks up people who just need reading glasses because they're age 40 or older, yet don't have them. Distance vision impairment is often, and in that PAF analysis, used as the marker of vision health. The prevalence of distance vision impairment that was used in that study, we actually did sensitivity analyses where we used a couple different prevalence rates, but it was somewhere around 11%, 11 or 12%. The prevalence of hearing impairment was, and feel free, Jennifer or Frank or Nick, to correct me, but was more like 25%. Even higher, Jennifer says. So it's driven mathematically entirely by the prevalence, the difference in PAFs. And that really varies setting to setting. Now I say this, so for example, if you did the same calculation in India, vision impairment is extraordinarily prevalent in India. The prevalence is very, very high, about 6 times that of the United States. And we see a very, very high PAF. In fact, vision is the number, I believe, if I'm remembering correct from that analysis that we've done, the #1 risk factor in a similar analysis.
Excuse me, if I could just interrupt briefly. Of course, the prevalence that's used should relate to the degree of impairment for which the relative risk was calculated.
Correct.
So it can't be complete, but I think prevalence is the reason that the prevalence of vision loss which compromises cognition may be much less than, except in India. So I agree with your points.
Yeah, I wouldn't say except in India, but there's other places with a high prevalence. I just happen to do work in India. But yeah, and in terms of the relationship with social isolation, I think you're probably right. I'm not a hearing researcher. You're probably right that we see social withdrawal at earlier stages of hearing impairment. But there's as well a fairly robust literature showing the relationship between relatively low levels of vision impairment, like levels at which one could still legally drive in all 50 states, and social isolation.
Thank you.
Mm-hmm.
Thank you for that great talk. I'm really interested by your comments on cognitive load. As I sit here and listen, it occurs to me that these academics have, a cognitive load problem all the time. And so, could you talk to the mechanism that's hypothesized with cognitive load, how that's moving to the brain, and then apply it to vision impairment?
Yeah, well, I can probably talk better about the second half of that question. There's probably some dementia researchers that could talk a lot better about the first half of the question.
Yeah.
The truth is, it's a little bit of a catch-22. There's the cognitive load issue, but we also know participation in cognitively stimulating activities is a good thing. So if you do crossword puzzles, that's supposed to be good and protective, and something we should be doing as we age. The sort of second half of your question is that, as when people are visually impaired, certain things require adaptations or require doing, depending on the level of vision impairment, require perhaps doing something in a non-standard way in order to get from A to B or accomplish a task, right? And so it's hypothesized that requirement of greater cognitive energy to get our daily things done, right? I'm not necessarily talking about the crossword puzzle, but our daily things, right? Preparing meals, bathing, sort of ADL type activities and IADL type activities, over time exerts a burden on the brain that could result in cognitive decline. And I know that there is a rich body of literature on this, but one that I'm probably not the most equipped person to speak on. And I think there are probably dementia researchers here that probably know that literature a bit better than myself. Yeah.
I was sitting here thinking toward the end of the talk that it's too bad we can't do a randomized trial on eyeglasses, and then lo and behold, they are in Clever.
We are, yeah.
How long is that waiting period? And I know it's not your study, but how long is that waiting period? And I guess secondarily, how do you sort of ethically justify? Wearing glasses has a lot more benefits besides just potentially preventing cognitive decline. How do you sort of justify delaying those other benefits for control group and that kind of trial?
Yeah, I mean, it's so I mean, I'm involved in the study. You're right. It's not, I'm not the PI, but it's the follow-up period will be a minimum of 3 years. We're hoping to get 4 years of data on follow-up. And so we don't expect to see a lot of incident dementia, but we hope to see a difference in cognitive trajectory, right? A difference between the curves. In terms of ethics, we are, we're not ultimately withholding the intervention, right? People will receive eyeglasses. It's not a life-saving intervention. It's potentially life-altering in certain important ways. But we're also not preventing anybody from getting eyeglasses either. Our primary analysis will be an intention to treat analysis, where if you get eyeglasses, hey, that's great. I think it's, for example, in the locally run Achieve study, right? Nobody's prevented from getting a hearing aid, even if you weren't randomized to receive a hearing aid. So I think it's similar in that respect. Hopefully that's okay to frame Achieve that way, Frank.
How do you test people?
Yes, that's a great question, and I figured somebody would probably ask that. So I will say that Alden has actually done here in this room has done some of the most interesting work in that space. Alden, please correct me if I characterize your work incorrectly. But Alden and others here at Hopkins asked the question whether or not there's differential item functioning in a couple different cohorts among those with hearing loss and with vision impairment in responding to cognitive tests that had a visual or an auditory stimulus, because almost all the cognitive tests have one or the other or both. And surprisingly, they did not find evidence of significant differential item functioning among those who were visually impaired for the visual test items, or among those who with hearing loss for the hearing items. Yeah, okay. So that was encouraging that we can do these analyses kind of using all of our data. I tend to very often or nearly always rerun sort of sensitivity analyses, omitting visually items with visual stimuli and kind of redoing the analysis that way. So just including the auditory stimuli if I'm interested in vision impairment. And I've never done that and seen the main effect go away, interestingly. Yeah, sure. Big vision component, yeah.
But yeah, I mean, that one especially, you have to be able to see what you're doing.
Absolutely. Absolutely.
Across studies, are the resources there to look at an auditory test? I mean, do most studies have both?
Yeah, I think most studies do have both because there'll be a word recall, for example, which has no visual stimulus. Certainly an auditory stimulus may be relevant when we're thinking about hearing loss. So I would say all studies seem to have both visual and auditory stimuli. Certainly you lose some data if you just look at one or the other. As I said, we're pretty bent on doing those sensitivity analyses for just that reason, because we do want to be sure that we're not measuring one's ability to complete the cognitive test rather than their actual cognitive health. That's a point very well taken, Alden or Jennifer.
I was just going to say that's a great summary. I would just add that the paper that we did that was led by Emma Nichols, we looked at this question of whether there are test differences by mode or by mode of administration, or by how the test is administered. In really strong, well-conducted, well-oiled cohorts in the BLSA and the BERIC study. If you're going to analyze data in other cohorts, you really need to pay attention to data quality, how the questions were asked, how adaptations were made if somebody does have a visual impairment.
Yep.
For example, are you going to just ignore the trail making test, or are you just going to forge through it? Maybe you'll give people size 14 font. What other adaptations may have been made? You want to know what the studies did.
Yeah,
Thank you.
if it's okay for me to add
Please.
on to that, I love this discussion so much, and I think the question of whether the measure of cognition you're measuring is valid is a really important question. But I also think it's really important to think big picture in terms of who's most at risk for dementia and cognitive decline, and it's older adults, and everybody has some form of sensory loss. So thinking bigger picture about ways in which we can be more inclusive, I think is also really important. And right now, there's a lot of, I mean, if you go look at, again, very well conducted studies, if you look at their protocol for testing cognition, they do everything possible to make that person feel comfortable, feel successful, maximize, right? So it's things like wear your glasses, wear your hearing aids, but that provides they have the right prescription and they bring them to the clinic. And so, you know, I think we are doing things now that are in that direction, but in my opinion, we don't have the best practices for measuring cognition in people with sensory. And so I think that's another good step in the field.
Yeah, and I would completely agree. Completely agree. Yeah, I mean, you know, and the trails test is probably prone to other issues as well, like a tremor. Right? So it's important to think about all those issues.
Thank you so much. Really interesting talk. Can you help me out with a little more clarity? Sometimes it seems like function was being measured, and others a measure of disability. Sometimes it was being viewed as something that could be correctable, right? Like,
Yep.
Where's most of the data, right? And sort of as you talked, it seemed like you were viewing it from some slightly different perspective.
Yeah, so so every study that I presented detailed data on used objectively measured sensory data, not self-reported. I did talk about how much of the data that we have way more self-reported data, and I've done a lot of work with that self-reported data, and I think it's measuring something important but distinct. I think it's measuring a highly correlated but distinct construct to what we measure with objective vision or hearing measures. I specifically focused on the objective measures to make sure that we were kind of comparing apples and apples, and that we kind of had like a consistent narrative there. But you know, you bring up a good point. I mean, vision is measured slightly different. Hearing is measured slightly differently from study to study. And so I do think it's important for us to do perhaps some of the less exciting work to make sure that if it's being measured differently, that it's at least close, right? That we have tight limits of agreement, that we don't have a bias kind of at the extreme ranges, right? With certain tests, certain non-gold standard tests. And so by and large, the studies that I presented were either, trying to think about each one, were either good clinical tests, right? That we're using like that clinical gold standard, or in the case of NHATS, we really went through great pains to take people from the eye clinic in Wilmer, some with normal vision, some with not normal vision in the right age range, and test them in a randomized order using the NHATS test, using the standard, you know, gold standard clinical measures, and make sure that we're really measuring the same thing. It's this measurement question again. So I didn't touch on the self-report stuff, but I think it's incredibly interesting and important to understand how people's perception of their visual ability influences things like their social well-being, their psychological well-being, how far they travel from their home, because these things are real, whether or not we pick it up with an actual physiological test or not. And so we've done quite a bit of work there. And I was actually talking to a grad student here earlier who's doing some exciting work trying to understand the concordance and discordance between some of those objective and self-report measures, which is an area that there's been very little published on, but is I think quite an interesting scientific area. Yeah. Hey, Frank.
So really nice talk, so I'll take you in a sort of different direction. Hear your thoughts. So big picture, I always think about a lot of times addressing the public health.
Yeah.
From a market-based perspective, there's supply and demand, right? There's supply of vision care services, technology, et cetera. And then there's also the corresponding demand, right? And obviously, you know, need is demand. There's need by definition for the cataract with that and needs have a demand. I've always been struck by on the vision side, my impression is that it's less of a demand issue than a supply issue.
Yeah.
Right. Because you have a vision problem, you have a cataract like that. So is it, I want to see if you agree, is it really like converting need into demand, how you do that, which is a huge, Or is it purely a supply side issue? Is it, if it's really a supply side issue, it changes the dynamic of like what's really needed to move the needle sometimes.
Yeah.
What are your thoughts?
So I actually think it's both. I think it is probably more a supply side issue in most contexts, but there is still, even in this country, I hear this from, I see patients 1 day a week. I hear this from my own patients. There is a perception that vision loss is a normal part of aging. And so I see people all the time who are acquiescent, right? I say, how are your eyes doing? How's your vision? And they say, well, not so good, but I'm getting older, right? And that's a problem because there's always something there. I can't always fix it, but there's always something there. And so if there's this perception, it means that things are going untreated. That's here. You look in other contexts where there's perhaps lower health literacy, whether that means outside of Ann Arbor, where I practice, or in another country where there's perhaps just overall lower health literacy. And that problem is amplified, right? There's just this acceptance of, hey, people lose vision, right? People in my village are blind. Now I'm blind. So there is that piece. I think that that's a smaller piece, at least here, as compared to the supply side piece. There's need, there's demand. Eyeglasses are not a Medicare benefit, except after cataract surgery. That's the one exception to that rule. So if you need eyeglasses and you can't afford it and you're not dual eligible, you just have Medicare, you're not getting eyeglasses from fee-for-service Medicare. And so there is a real policy issue. We thought that was going to be addressed in a bill about 24 months ago, and it got pulled from the bill, as you know. So there's discussion on Capitol Hill, but there's not been any definitive action to address that. And I see that as probably the biggest policy piece that can make a difference, is making eyeglasses a standard part of the Medicare benefit. Does that kind of address what you're?
Okay, any final questions? Nothing on the chat now?
Well, thank you all very much. I appreciate the opportunity to be here and spend some time with you.
Great job.
Now that you can say it, I think that would be us. So basically, kind of